Hello, and welcome to today's episode of the VJ Hem-Onc podcast. In recent years, there's been a significant shift in the treatment of acute lymphoblastic leukemia, or ALL, driven by the emergence of novel immunotherapies, such as bispecific antibodies, antibody-drug conjugates, and CAR-T cell therapy. In this episode, leading experts explore how these advances are changing the treatment landscape and where the field is headed next. To begin, you will hear Marlise Luskin outline emerging treatment strategies in ALL and highlight the potential for reduced reliance on intensive chemotherapy with the integration of novel therapies into clinical practice.
As a specialist in acute leukemia, I treat a range of diagnoses, both myeloid and lymphoid acute leukemia, as well as other chronic myeloid disorders. So I have experience treating a range of patients with hematologic malignancies. And as you point out, ALL has had even standing out among that group. This is a disease where we've seen a proliferation of treatment options for our patients, including targeted therapies, particularly for Philadelphia chromosome positive ALL, where we've seen the development of increasingly potent and effective BCR-ABL inhibitors, and then immunotherapies, including immunotherapies that are directed against CD19 and CD22, bispecific antibodies, the blinatumomab, CD19, CD20 bispecific, and CD22, an antibody-drug conjugate, inotuzumab, and some other bispecific and antibody-drug conjugates in clinical development are coming behind. And then we have cellular therapy, the CAR-T cell therapy, as you alluded to. We now have 3 approvals for autologous anti-CD19 therapy. So it is great to have so many tools in our toolkit. And what we're seeing is a proliferation of clinical studies for both Ph positive and negative in different age groups, really trying to discern how can we use all of our agents with the best efficacy, the least toxicity, and for these different subgroups. Bringing these novel therapies that have often been developed first in the second line or the relapse setting and bringing them to the frontline setting. And then as we integrate into the frontline setting, figuring out how to integrate 1 or 2 together and how the chemotherapy should be adjusted in terms of adjustment, often decreasing the intensity of chemotherapy to improve tolerability. So as we move forward, I think we're going to see less reliance on chemotherapy, more reliance on novel immunotherapies and targeted therapies. But, we have to proceed cautiously. We know that there are certain limitations of the novel therapies, including efficacy against CNS disease, potentially less efficacy against extramedullary disease. And there may be certain subtypes that are more vulnerable to immune escape from cellular and immunotherapies. So we need to make sure that we move aggressively. We don't want to wait many, many years before making bold moves, but also pay attention to the long-term outcomes and figure out what is the best balance of the old and the new. With the answer for that question may be different with different age groups. With younger patients still benefiting from some chemotherapy, and maybe the oldest patients who have the most toxicity really going real slim. So I think we're going to see this landscape changing rapidly. I will emphasize, unfortunately, that our progress in T-cell ALL has not been as rapid, and we don't have as many of tools in our toolkit. We've had some promising trials, and there are ongoing trials looking at targeted therapy and novel approaches, but that's an area of really unmet need, and hopefully we'll see folks doing further research, basic science research, and clinical investigation for that from that disease sector.
Next, Martin Schrappe shares insights into a trial evaluating the bispecific antibody blinatumomab as a replacement for high-dose chemotherapy in pediatric patients with newly diagnosed high-risk ALL.
High-risk ALL is the minority of patients with ALL in this age group. But nevertheless, they are carrying a significant treatment burden because they need the most of chemotherapy. So in the past few years, this was a little bit frustrating because the side effects are quite significant, the acute, but also the late side effects. And therefore, we wanted to introduce something which is less burdensome for the patients. And this we hope would be immunotherapy using a bispecific antibody called blinatumomab. And we randomized blinatumomab instead of 2 cycles of very heavy chemotherapy versus the conventional arm using the full-scale chemotherapy. And the primary aim was very clear very soon that this is less toxic, but we didn't know if it's also at least the same, if it delivers the same efficacy or even better efficacy. And in the end, and this will be reported here, we could show that the efficacy was actually much higher, significantly higher than even the group of patients who received the standard chemotherapy. I think this marks a real turning point in leukemia treatment because it shows that you can back off from toxic chemotherapy and be able to replace it by cycles of immunotherapy. In the long run, we will see how much you can reduce because we don't want to risk the overall achievement in childhood leukemia, which is a survival of 90%.
Earlier this year, the 8th International Workshop on CAR-T and Bispecifics took place in Tampa, Florida. You will now hear a joint discussion from the event, in which Ibrahim Aldoss and Bijal Shah focus on the future of T-cell engagers and CARs in acute lymphoblastic leukemia.
Hi, I'm Dr. Bijal Shah from the Moffitt Cancer Center.
Hi, I'm Dr. Ibrahim Aldoss from City of Hope in Duarte, California.
We're both here at the IW CAR-T 2026 meeting. I'm both delighted to be here. Ibrahim, you gave a phenomenal talk about where we're moving in B-ALL with bispecifics. What do you think were some of the key takeaways?
Thank you, Bijal. I mean, it is an exciting time now with the new bispecifics that they appear to be safe as well as highly effective and can salvage some patients who failed prior CD19 target therapy, including blinatumomab as a bispecific antibody, as well as CD19 CAR-T cells. An advantage of these bispecifics, it's the convenience of administration. It's given intermittently rather than continuous infusion. So it's more practical to implement in relapse refractory setting and possibly moving to the frontline therapy. But also the other advantage is the high efficacy we're seeing with this bispecific antibody that potentially can bring them to the frontline therapy to improve the outcomes of patients with newly diagnosed ALL and improve the curability rate and possibly even shorten the duration of treatment, reduce the chemotherapy backbone part.
You know, one of the things that I was really fascinated by in the presentation you gave was the activity of some of the newer bispecifics in places where traditionally we don't see, very high response rates or a propensity for relapse. I think one you mentioned was extramedullary disease.
That is correct. At least in preliminary data from the CIRUS study with the use of single-agent sorvatimig, we're seeing that patient with documented pre-treatment extramedullary disease involvement, that they are responding to sorvatimig, unlike what we have seen with the continuous blinatumomab, something we see similar to the CAR-T cell therapy. So we're very excited about this actually observation. And hopefully it can prevent some of the relapses we see when we implement blinatumomab as part of initial therapy.
I'm going to ask you to put your prediction cap on CNS disease. Do you think we'll get there with AZD? I mean, we're getting there with Glofit and with EPCO. We're starting to see some activity.
Yeah.
You think AZD will get us there?
It's really hard to see. I mean, my impression so far, we haven't seen CNS relapses on the CIRUS study, but I think there is plan to actually check the concentration of the sorvatimig in the CSF. I think the recent amendment of the study was approved, and hopefully we'll learn more as we actually evaluate the concentration of the drug in the CSF.
Fantastic. Fast forward, we're now 3 years from now. Sorvatimig is FDA approved. The MK-1045 compound is approved. Subcu blend is approved. Are these relapse refractory agents?
No, we're more actually excited how we can actually have more patients receiving these effective and potentially safer, more convenient drugs. So the goal, we're already thinking about it, how we can introduce these drugs in the older patient with kind of chemo-free light or chemo-free regimens and pH positive, as well as a chemo-free regimen with TKI, as well as implemented in the AYA treatment where we can actually reduce some of the toxic chemo backbone. So, Bijal, let me ask you a question about your presentation. Very exciting presentation. Where are we going with CAR-T cell therapy? And I think the question always, which patient more prone to have these durable, excellent responses in the relapse refractory setting without the need of consolidation with transplant? Can you summarize what we know so far?
I think it's a phenomenal question. One of the things that we're seeing now in clinical practice as we treat, much larger number of patients, well, one is the response rates are, if anything, better than what we saw on the pivotal trials. I think Karen Jacobson had mentioned this when she was talking about large B-cell lymphoma yesterday evening. It's interesting, as we treat sicker patients, we're actually seeing improvements in outcome. And certainly that's reflected in with what we're seeing with Brexucel and Obicel. And so I hope that trend continues. But we're also now getting an opportunity to see, okay, yes, we're seeing these very high response rates, but who are those patients that are prone to relapse over time? It's not going to surprise you. It's the TP53 mutant patients, typically or almost universally actually progressing with CD19 negative disease. We're seeing the same phenomenon in some of our pH-likes, but what's interesting about the pH-likes is they're not sort of true pH-likes in the sense that they also tend to carry these PAX5 rearrangements, these mutations that sort of compromise B-cell identity, or at least give them the potential, so that they're maybe able to escape it again through that downregulation of CD19. A few other genomic subsets, but I keep coming back to this idea of genomically driven care for ALL, because I think those mutations are telling us a lot about the identity of the leukemia. And by that same virtue, hey, what are we going to do to get around it? What are we going to do to enhance our outcomes for these patients? And it may very well be transplant. I really like the study that you had conducted at City of Hope, and this is using your CD28 sort of T-cell memory enriched product. This is a CD28 product, right? So we know that the lifespan's a little bit shorter, but in very high-risk disease, again, you enrolled TP53, you enrolled ZNF384s, you enrolled all these subtypes where, again, we're thinking, these are a little bit tougher, but you're seeing durable responses. And one of the things that I thought was really neat, I want you to comment on this, is you gave blinatumomab before the CAR. Do you think that might have had some impact?
I think it's the depth of the remission in this patient, maybe what impact, and maybe it's actually didn't impact the quality of the T cells we transduced with CAR. Because in my study, most of the patients receive either chemo-free or chemo-light induction because it was more geared toward older patients. I think it was like 83% had prior blinatumomab, either induction consolidation. So that made it actually, but it's really hard to know. We have to look at the single cell analysis of the quality of these T cells and kind of compare it with the patient who received more chemotherapy rather than blinatumomab. So that could be part of it. And this actually brings me, Bijal, to the question is, where do you see CAR-T cell therapy in the frontline therapy, and how close we are to become, hopefully in the near future, a standard of care where we can shorten the duration of treatment?
I'm really excited by what CAR-T has brought in the relapse refractory setting. We've improved survival by, 2 to 5-fold. And it's massive. And I think it warrants the study of incorporation in earlier lines. I think people are rightfully concerned about the toxicity of CAR-T. What is that going to contribute to the, longevity? What we're seeing, again, from these relapse refractory studies, actually, it's probably less toxic than prolonged chemotherapy. Mortality rates in the first 90 days on a range of 5%. And even when we extend it out, 2-3 years, we're talking about more, again, non-relapse mortality. I should be more specific. Non-relapse mortality is quite low. Is quite low on the range of, probably 10 to 15%. And that's, all comers, right? Not even things that necessarily related to CAR-T cell therapy. So I'm really excited about what we're doing to bring this front line. And I think that the trials that are being studied, your study in older patients, our study focusing on MRD, MD Anderson's study focused on those patients who have high risk genomic features, but with the goal of getting the CAR in an MRD negative state, are all shots on the goal. One study that I'm really excited about is one that's coming, and I think you guys may be participating on this study. It's no longer going to ask the question about risk. In fact, it's simply going to say, after induction chemotherapy, if you're MRD negative, can we deliver CAR-T cell therapy? Meaning, can we take our lowest risk patients and eliminate 2.5 years of therapy and derive, and derive cures? And I think even if we only hit that, at 70 or 75%, even if that's where we land, we just saved patients years of therapy, and by virtue of taking on lower risk patients, retain the ability to salvage them with AZD, with, Merck, the 1045 compound, with, subtubulin, with whatever we want. And I think it's such an incredible next step forward. I think that what we're going to increasingly see are going to have to be randomized designs. But certainly knowing what we know about how these drugs perform, or how these CAR T cells perform, boy, I mean, put me in that position. Dr. Shah, you can take 3 years of therapy, or you can shortcut it and do a CAR.
But do you think we need a randomized study to kind of get these actually CAR T cell therapy in frontline?
For high-risk patients, no. But for all comers, I suspect the FDA is going to ask for. I mean, it does meet the definition by the FDA of an ultra rare disease, right? 3,000 adult cases in the U.S. per year. But at the same time, I suspect they're going to want a randomized design for FDA approval. Now, NCCN is a different story, and what happens in that context is a little harder to predict. But I think that it's probably where we're going. I'm also really excited about what we're doing outside of the CAR itself. You heard me allude to that when I talked about giving blin to improve T cell biology going into the CAR. There are also things we can do with lymphodepletion that we haven't even begun to explore. We're still in a flu-cy era. And I think that's terrible. We have so many directions, so many immunomodulatory things we can do as a component of that LD that we haven't even begun to dig into. And then, of course, we have to talk about all the new technology with the CARs themselves, right? What we're doing with dual antigens, in vivos, and I could go on. But it's really exciting.
Bijal, I would add also, as we actually have a more targeted therapy for the different subtypes of the leukemia, TKIs for Philadelphia chromosome positive inhibitor for KMT2A. Do you envision that, it will be similar to the transplant patient going to remission, receive CAR, then they will be on the maintenance?
I'm glad you asked me that. Why do we transplant? My transplanters keep telling me there's this thing called GVL, right? Where the graft attacks the leukemia. Is CAR any different? Yeah. And I'm saying that as a provocative question. When Scott Rodig went and biopsied patients with lymphoma 10 days after, 98% of the cells were actually non-transduced T cells that were just part of the product that was infused. And, when we talk about T cell health, when we talk about, what it means to derive cure in ALL, we may be transplanting by virtue of giving CAR-T in and of itself. And so we have some room to go. And again, I'm excited by some of the trials that are going to enhance T cell health and enhance T cell biology to help us inform those outcomes, including the bispecifics.
Thank you, Bijal.
And thank you, Ibrahim.
As mentioned by Dr. Luskin earlier in this episode, effective treatment options for patients with T-cell ALL remain limited, and this has prompted investigation into novel therapeutic approaches in this patient population. To conclude this episode, Nicola Maciocia shares insights into advancements in CAR T-cell therapy for T-ALL and highlights ongoing research aiming to identify the most appropriate target antigen in this disease.
So there's been quite a lot of changes in the field of CAR T-cell therapy for T-ALL, I guess, in the last 5 years or so. And the antigen that's really come out as the kind of leading antigen at the moment is CD7. So we now have a number of published trials of CD7 CAR T-cell from around the world, both phase 1 and phase 2 trials, both of autologous CD7 targeting CAR T-cells and allogeneic targeting CD7 CAR T-cells. And at the moment, one strategy or another hasn't really emerged as a lead candidate at the moment. So the CD7 CAR-T trial data has been really exciting for the field, particularly for T-ALL, because I guess it's really shown proof of principle that T-ALL blasts are just as susceptible to CAR-T targeting as B-ALL. And obviously we've seen really revolutionary advances in the treatment of B-ALL, and we really hope to replicate that for patients with T-ALL. So for us in the field, the CD7 data has been really exciting because what all the trials have really shown, whether they're autologous or allogeneic, kind of what methods of manufacture they've used, they've all shown these really high initial complete response rates and really being able to achieve very great depth of response. So putting people into kind of MRD negative responses, particularly in bone marrow disease. But while that's been very exciting, there's a number of limitations with the CD7 CAR that have begun to emerge as we've got more advanced clinical data from some of these trials. So the first I would say really is that these responses do not appear to be durable. So the vast majority of patients in these trials have progressed to an allogeneic stem cell transplant after their CD7 CAR. Now that has been largely because of the kind of T lymphocyte depleting effect of a CD7 CAR T cell. So most patients go into a state of T cell aplasia, and obviously that's very toxic, and patients are at risk of a lot of opportunistic infections. And so the stem cell transplant really is used as a means of rescuing patients from that T cell aplasia and resetting their immune system. But what we've seen in the minority of patients who haven't proceeded to a transplant is that a large proportion of those patients seem to relapse after their CD7 CAR, and that can be with CD7 positive or CD7 negative disease. So I think the data on the CD7 CAR from around the world is very exciting. I think there's still a way to go to improve the CD7 CAR. And at UCL, we're interested in different approaches to try to overcome some of the issues for TALL. So in my talk yesterday, I spoke about two antigens that we've been developing. One is a CCR9 targeting CAR and one is a CD21 targeting CAR. These are what we would call T lymphoblast restricted antigens, in that they are expressed on TALL, but we don't think they're expressed on the majority of normal T cells. So we hope that our CCR9 and CD21 targeting CARs will be effective against TALL without the same T cell aplasia and toxicity that has been seen with the CD7 and other pan T cell targeting CARs.
Dr. Maciocia also discusses whether cellular immunotherapy represents the most promising approach for treating patients with TALL, and comments on the possibility of cure in this leukemia subtype.
I do think cellular immunotherapy is the most promising approach for patients with TALL. Despite a lot of research into new treatments for TALL in recent decades, we've really seen no new targeted therapies emerging. And I think that's in part because TALL is an extremely genetically heterogeneous disease. And so I think it would be difficult with a kind of targeted molecular drug to reach a large number of patients with TALL. In TALL, I think an approach that is not reliant on the sort of genetic mechanisms of TALL, such as targeting a surface marker, is going to reach the vast majority more patients than a more molecularly targeted therapy. I think we are not far off achieving a cure for patients with TALL. If you look at what's happened with BALL and CAR-T cell therapy in the last sort of 10 years, practice has changed significantly in that time. And we now have got patients with, relapsed and refractory BALL that are cured of their leukemia by CAR-T cells. And I think the emerging data with CD7 CAR is showing that these lymphoblasts are highly susceptible to CAR-T cell therapy. And I think if we can overcome some of the challenges that remain in targeting a T cell cancer, then we can certainly see the same durable remissions with CAR-T cell therapy for TALL. So we're very excited that it's eminently possible and can be achieved in a relatively short time frame.
Thank you for tuning in to this episode of the VJ Hem/Onc podcast. For more updates and expert insights, make sure to visit our dedicated ALL channel on vjhemonc.com. Don't forget to follow us on X at VJ Hem/Onc to stay in the loop, and subscribe to our podcast on Spotify, Apple, or Podbean so you never miss a new episode. Until next time.